Thanks, Linda.
Okay.
The next question is a request to comment on bringing new providers into the PCMH. Should a physician practice focus on fixed payment, that is bringing on more patients, increasing the panel size, or other elements of PCMH financing? So I think this is more sort of payment and finance related. I would say that it's hard to generalize. It really depends on what infrastructure is already in place. For example, if you've already made the fixed investment of implementing an EHR, then the incremental cost of bringing another provider in might be smaller. And so you would factor that in. I think it would also depend on the specific payment model that you were working under. What was the relationship of fixed payment versus shared savings? If you're getting more on fixed payment, then I think that's going to suggest a certain strategy versus whether you have more opportunity on the back end. I mentioned earlier that in some programs there might be minimum population sizes, which might give you an incentive to bring in new providers, at least up to a certain level, so that you could meet that minimum threshold. So I think there's a number of different factors that you'd have to consider in terms of the structure of the payments, but because those factors vary, it's hard to generalize about what the best strategy would be. And of course, as providers, you also need to think about the culture, and this is more in Linda's area, but you need to think about culture. Is this the right fit? Are you bringing on a provider who's actually going to be on board with patient-centered care? That's probably the primary criteria that would trump any of the other financial considerations. The next question is, since one person's healthcare cost savings means another person's reduction in compensation somewhere in the system, how successful will PCMHs be in engaging necessary hospital and specialist involvement when ultimately it means less money for them? That's a very sort of interesting and challenging question. I would say it becomes more of an issue when we start talking about accountable care organizations, because accountable care organizations typically would include hospitals and specialist physicians as well as primary care providers. And so for them, savings actually means a direct reduction in their own patient care revenue, potentially. For a PCMH, however, since most of the reductions take place outside of their office, and they're upstream from a lot of these care providers like hospitals and specialist physicians, they do have the ability to generate savings through their own direct efforts. And I think a lot of specialists and hospitals and other care providers, recognizing that this is the direction that the healthcare system is heading, are really working hard to position themselves to be effective partners for patient-centered care. So while it might mean a restructuring of their business models, in the long term, that's going to be necessary for them to sustain themselves, and probably where all of this heads in the long term, and in a way that makes hospitals and specialists and primary care providers all sort of in the same boat, is global capitation or these other payment models where everybody collectively is at risk for the total cost of care. And so then the hospital itself is happy when the admission rates are reduced, or specialists are happy when primary care physicians can handle basic chronic care management. So there are a lot of interrelationships in the system that have to be accounted for. But when we're just focused on the PCMH, we think that the primary care practice can exert enough direct influence to drive the savings that can sustain that model. The next question is another finance-related question, and it is, when speaking about the payments, when there is a threshold to share in the savings, if they do not meet the threshold, you describe the practice, I described it as the practice getting nothing. Isn't that misleading, since the practice is getting a care coordination fee prospectively, and at least in this questionnaires program, they keep that no matter what? And that's a very good point, that in a typical PCMH payment model, the provider does get some of that fixed payment up front, and they get to keep that. But do keep in mind that for many of those practices, they have then spent that money on installing an EHR or hiring a care coordinator or making other infrastructure changes. So for most practices, I would argue that the fixed payment is only going to offset their additional investment in becoming a patient-centered medical home. And in many cases, they actually still may be out of pocket for some of those expenses. So unless there's a way for them to achieve shared savings, it's unlikely to be financially an attractive model for them. And I think that much of this requires an appropriate balancing of the fixed payments versus the shared savings versus the existing fee-for-service revenue streams. But where you do have shared savings, it makes sense to keep, again, everybody in the game, and in a way that doesn't make it an all-or-nothing or a sort of a win-lose proposition, but it keeps everybody in the game on a kind of incremental, gradual scale. The next question is, Linda, for you, if I can cue it up here. So Linda, the question is, in the nascent stage of PCMH development, do you believe the preferred model should be to focus on identifying a practice's chronic condition patients, or is a more general patient population approach more valuable?
Well, I don't see that as an either or, really. I think that the patient-centered medical home centers on the patient and looks at the needs of the patient. And the patients with chronic conditions, the patients who are at high risk because for one reason or another they end up in the emergency room or the hospital more than they should, they should take more of your time and attention. And in fact, they're the people that you are going to have the most cost impact on because their expenditures are high. Now, that's not to say that you ignore the rest of your practice. The other folks need attention in terms of keeping up their preventive checks, in terms of dealing with acute illnesses when they come up, in terms of dealing with minor chronic illnesses. It's more a matter of attuning the time and attention to the needs of the patient.
Thank you. The next question is, what is the Medicare minimum population size? And so Medicare has specified a minimum population size of 5,000 patients, but keep in mind that that's for the Accountable Care Organization Shared Savings Program, not a PCMH program. And so because Accountable Care Organizations are systems that also include hospitals and specialist physicians, one might expect that to be a larger population than you would see in other settings. The next question is regarding the discounting of fixed payments, and the question is, the 40% discount rate seems high. Is that realistic? And it is a high discount rate. Generally, when selecting a discount rate, what you try to do is find something that's comparable to the project that you're analyzing, and then apply a discount rate that would be reflective of the risk with that comparable project, especially where you have market-priced risk levels. So, like the stock market historically has returned a 12% return on investment, so one would use it. If you thought that the risk of an investment was about the same as a publicly traded stock, you might choose a 12% discount rate. And 40% is in the range of the discount rate that investors use when investing in a startup business. And again, it's a high rate, but it reflects the uncertainty, the high uncertainty of whether that investment will actually produce value. I would guess that as a practical matter, that discount rate would be a subject of negotiation between a provider group and a health plan. and certainly the provider group would argue for a lower discount rate, and perhaps could successfully argue for that if they had already demonstrated the ability to drive savings, if they'd already made some of the investments and had a track record of delivering patient-centered care. And then the final question we have, and Linda, this is for you again.
Okay.
How do you see the role of the hospitalist evolving in terms of coordination of care post-discharge for complex chronic care conditions such as diabetes?
Mm-hmm. Well, the hospitalist is one of those really important neighbors of the medical home. And the person that, increasingly the primary care practice depends on to communicate information about the patient who's been hospitalized. Where that does not happen, and it does not happen, unfortunately, in a lot of cases, that's where getting out of the hospital is the most dangerous point in the healthcare system. Because what the hospitalist needs to communicate to the primary care physician is what's the patient's status right now, what are the medications that patient has been receiving in the hospital, what's the status of his health. You need to pick him up now and go on. I've actually seen this work perfectly in a hospital system where the primary care practices happen to be allied or owned by the hospital system, and where the hospitalist got that electronic care record directly to the primary care physician, who called the patient as soon as she got home to say, what's happening, and I need to see you tomorrow. The same records were shared by the specialists who cared for the patient in the hospital. They also coordinated their work with the primary care physician. So I think the hospitalist is very important, and it's very important that they be open and ready to coordinate information with primary care. Thanks.
Thanks, Linda. And thanks to everybody for attending today's webinar. As we said, we'd encourage you to follow up with us if you have any additional questions, if you'd like a copy of the slides. We certainly look forward to hearing more about the work that you're doing and exploring ways in which we can work together. So this concludes the webinar. Thanks again for attending, and we hope to talk to you soon.